Hello everyone and welcome to CBCLIPS. This CBCLIPS episode was a lot of fun because nobody actually guessed the correct diagnosis. And just to comfort all of you, I also did not know the correct diagnosis before I intervened in this patient. And so I'd like to use this case to discuss gallbladder disease in children, but also to discuss an approach to a difficult presentation such as this, which is not unusual in pediatric surgery, where we struggle to make the correct diagnosis and decide on the correct intervention. This was a 4-year-old girl, previously healthy, tested negative for COVID, who had 3 days of generalized abdominal pain. And when she presented, she was mildly tender, diffusely, but had no peritoneal signs. And then we're surprised by an ultrasound that shows us a thickened gallbladder without stones, essentially a picture of acalculous cholecystitis. But why would you get acalculous cholecystitis in a previously healthy toddler? So this represents really a surgical enigma or a diagnostic dilemma, and that's how I would like to go about discussing the case. But before we do that, let's just quickly review gallbladder disease in children. I often classify it as that associated with cholelithiasis and that which is not associated with cholelithiasis. Now, in the cholelithiasis group, we essentially have 3 cohorts of patients. Those who have cholestasis, for example, premature babies who may have been on TPN for a long time, or babies who had a GI abnormality and could not feed for a prolonged time. The second category are patients with hemolytic disease who form bilirubin stones, such as sickle cell patients, spherocytosis patients. And then the third are the typical cholesterol stones we are seeing more and more because of the obesity epidemic. And then the other group are those without cholelithiasis. For example, patients who may have choledochal cysts or other hepatobiliary abnormalities. Patients who present secondary to another disease. For example, we know that hydrops of the gallbladder can develop with Kawasaki disease. And actually, some people mention that this was hydrops, and it's not, because hydrops is a very distended gallbladder with a thin wall, which this was not the case here. And then some rare problems that we see from time to time that are really all described essentially in case reports or small case series, such as, for example, an entity called primary gangrenous cholecystitis in middle children. So when we have a difficult case like this, how do we approach it? Often we engage in what we call fishing expeditions, doing a lot of tests, and sometimes tests that actually may require, for example, a general anesthetic such as an MRCP, without really knowing exactly what we're looking for. My suggestion is to follow this QRST approach. What is QRST? Well, every intervention we do should be query-driven. We should be trying to answer a specific question. There should be a rationale for an intervention, especially if it's going to be an invasive intervention. We should follow a stepwise approach, and we should see what the trajectory of the patient will be as we follow this stepwise approach. And I will give you now an example of how we employed this in this very difficult patient. So we admitted the patient, we put her on IV fluids, we started antibiotics, and we repeated her exam frequently to see how she will progress. We allowed her to take PO intake, and we repeated her labs in 48 hours. And we followed the trajectory of her disease, and interestingly, we found that there was really no deterioration, but also no improvement. She continued to have the same symptoms. Her oral intake was extremely poor. She continued to have vague abdominal pain despite no change in her physical exam. And the one thing that changed was her CRP normalized, which was not super high in the first place. So we repeated an ultrasound 72 hours after admission, asking a specific question. With our intervention, were there signs of gallbladder inflammation resolving? And what we found, in fact, was that things were getting worse. The gallbladder was actually thicker, and now there was an appearance of significant inflammation around the wall with a lot of echogenic material and some fluid collections. So with that, we decided it was time to intervene with a presumptive diagnosis of primary gangrenous cholecystitis, which we had seen before on our service. When we went in by laparoscopy, there was a large right upper quadrant phlegmon. You can see here on the picture on the left, significant omentum plastered to the liver. And when we peeled that off, we found a gangrenous gallbladder. So we thought, okay, we made the right diagnosis. But in fact, the gangrenous gallbladder was not a primary process. It was secondary to a volvulus of the gallbladder because we could not identify any structures in the triangle of Callot. We reduced the gallbladder 360 degrees and we finally could see the triangle of Callot. And once we divided the cystic duct, the gallbladder literally fell off the liver. So this was a rare presentation of gallbladder volvulus, something that I knew could happen, but had never seen and actually did not predict in this patient. So again, this patient really exemplifies the QRST approach, which really I think is useful in any surgical enigma, many of which we encounter in pediatric surgery. Query-driven, having a rationale for intervention, following a stepwise approach, and seeing the trajectory of disease. This was the last CBCLIPS of 2020. CBCLIPS will take a Christmas holiday and then return in the new year. I want to thank so many of you, trainees and surgeons and pediatricians and others from around the world who have given me feedback about CBCLIPS and who've used it as an educational tool and who have participated. Thank you so much. And I invite any of you who is interested in being a guest presenter of CBCLIPS in the new year to let me know, and I would be very happy to help you present a CBCLIPS of your own. I want to wish all of you who will celebrate Christmas a very merry and peaceful Christmas, a happy Hanukkah to those who will celebrate Hanukkah, and a very happy New Year to all of you. We pray and hope that the new year will bring us much relief and much hope after the very difficult year we've all been through. Thank you so much.